Thanks. Good afternoon, everybody. I appreciate the opportunity to speak today. So these are my disclosures, including a note of disclosure from Paragonix for speaking. So I'm going to talk a little bit about sort of the background of kind of the landscape in the U.S. in terms of longer distances traveled to get our organs. I'll talk a little bit about Stanford's kind of initial experience with the Paragonix device and some comparison to our historical controls. It's a little hard to follow up a 1,000-patient registry with sort of our local experience, but maybe I can give you just some of our thoughts as we've kind of gone through this process of changing the way we obtain and preserve our donor hearts. So certainly everybody in the U.S. is familiar with the fact that the allocation changed in 2018 and how it's impacted how far we go. So when you look at any of one of a number of studies, not this one study in particular, but I think they all show this, that we're going further. And as a result of us going further, the cold ischemic times are getting longer. But one of the benefits is we've seen the patients are actually not waiting quite as long because of the change in the way we allocate the hearts and more statuses, among other things. So how has that sort of impacted Stanford? So how have we seen this? If you look at our numbers sort of over time, this is a little bit backwards from maybe the way you're used to looking at, but the more recent data is on the left and the more distant data is on the right. And if you go back to sort of the old way that we allocated hearts in terms of DSAs and then increasing distances, you can see that we've gotten closer to the left-hand side of the curve. More recent data, we've gotten fewer and fewer of our hearts from what was the old DSA. We've started going a little bit further from the next step out in terms of 500 nautical miles, and then 1,000 and 15 and over have become sort of relatively routine in our practice. But at the same time, our program has grown too, so we've managed to increase our transplant volume over that time, despite the fact we're having to go further to get our hearts. And so what's Stanford's program like? Well, we've generally been pretty aggressive. So this is data from our SRT, our reports. They kind of compare the way you accept hearts and the kind of hearts you accept with everybody else and create a bell curve and show where you are. So the CASU, that's Stanford, and so we're kind of many standard deviations over to the right-hand side for our overall acceptance when we're willing to accept risk. So depending on sort of how you look at the PHA's increased risk kind of looks the same in terms of those donors. Looking at offers over offer number 50, we're kind of way out there. Donor age 40 or more, we're kind of way out there. And so we see the same thing with going over 500 miles. We're kind of way out there. So we're used to going very far. But at the same time, I think it's helped in that we've been able to get our patients transplanted faster as well. That graph on the bottom there that's oriented vertically rather than horizontally is the likelihood ratio of getting transplanted. In our center, it's about 3.5 times what we would expect because our program is big and then we can afford to take risk, and so therefore we're aggressive. So how has this changed the location of our donors and how we look at hearts in California? So the middle of that circle is San Francisco, and the circle is 500 nautical miles. And so it used to be that we would have access to our local DSA, which was around the San Francisco area, and so that was about 7.8 million people. And John Kabashagawa and the programs in LA would have access to a lot more local hearts. They had about 13 million people. But with going out to 500 nautical miles, we're all competing with each other across the state of California now to get our hearts. So how has that impacted us? Well, you know, when we think about transporting those hearts, 50 years ago, we'd say, okay, we'll put it on a bucket of ice and bring it to Stanford. But the honest thing is now we're still mostly thinking about putting in a bucket of ice and transferring it to Stanford. You know, there's other things coming along, including Paragonix, but you think, you know, what has changed in the past 50 years in transplant? A lot has changed in the past 50 years in transplant, including me. If I've changed this much in the past 50 years, how come we can't change how we transport a heart from one place to the next? I was a little fat kid. So our surgeons started saying, boy, when we do these long distance procurements, that comes back and like the right ventricle is frozen and other parts of the heart aren't as well preserved, and what can we do? So that's kind of what initially prompted us to start using the Sherpa pack. And so these are some of the temperature runs that Andreas mentioned before, from looking at short runs to long runs, and you can see that we're able to maintain the donor heart within a relatively narrow temperature range, kind of regardless of how long we're transporting that heart. So when we first started to kind of look and say, okay, what do our results look like over the first 6 months or so? And these weren't used in all of our transplants, but increasingly most of our transplants. So the hearts are where the hospitals were that we were getting our donors from. And the number below it is the miles away from San Francisco in just sort of straight line distances when you Google it, to just give you a sense of sort of where they were coming from. So over a relatively short period of time, about 6 months, the latter half of 2020, when you looked at the total hearts that we procured with the Sherpa pack, was just under 50, and the mean ischemic time was 254 minutes, and the distance traveled as a mean was 622 miles. And so to give you a sense of outcomes, so the blues, when the hearts turn blue, that means that heart had PGD, and we define PGD as need for MCS, so anything a balloon pump or higher, and most of them were balloon pumps. So there's 6 episodes of PGD, 4 of 6 totally recovered, and we just defined totally recovered as an EF of 60% or greater. And there was 1 death, and that death was procured from LA, so it wasn't a death procured from a long way away. And the median length of stay in the hospital was about 18 days. Our UNOS and SRTR reports were median is about 17 or 18 days. And so as we saw this, we're like, hey, we're getting more comfortable going further away. And so the question is sort of how far can we push it? And the furthest we pushed it in kind of this thing is going to Alaska. So how far away is Alaska, Anchorage from San Francisco? It's about 2,000 miles. And so for our European colleagues, 2,000 miles is about the straight line distance between Barcelona and Moscow. And so you can see that the ischemic time was 428 minutes, pretty long time, but it was a younger donor, it was size matched well, and there was absolutely no PGD in that donor. So we started using it pretty routinely, and now we use it for just about every transport. So I'll just show you some data looking at our historical controls compared to what we do now. So it's, it's roughly 60-60 in terms of ICE transport and Sherpa transport. You can see the time periods. It goes to the middle of 2020. Prior to that was ICE. After that was almost exclusively Sherpa pack. For this particular analysis, we're excluding multi-organ transplants, and there was 1 patient that didn't consent to being in our database, so that person was excluded as well. So we wanted to look at things like you've heard from Andreas in terms of death, PGD, again defined as a balloon pump or higher in terms of the need for support, length of stays, and ejection fraction. And when you look at the baseline characteristics, there's not much difference between these 2 groups. There were more VADs in the older cohort, not surprisingly, and this is just reflective of sort of what's happened in the US after the 2018 allocation change. So overall ischemic time, a pretty broad range of ischemic times for both groups, but statistically significantly longer in the group from a Sherpa pack, 255 versus 230 minutes. And so for the graph to give you a sense of sort of what's changed before and after, so the blue hearts are the hearts from the ICE storage, and they're going to go out to the center of the OPO. So wherever the OPO's office is located, because it got too messy on the map because there are too many hearts, and it ends up just being a blue mash. And the numbers below them are a number of hearts from that OPO. So this is what it looked like before we started using the Sherpa pack. So mostly concentrated on the West Coast. And afterwards, we started going further and further, all the way out to Kansas, Texas, Dallas to get our hearts. And so I think particularly for these long distance travel, I think we feel much more comfortable going that far using the Sherpa pack. So outcome-wise, I already mentioned the difference in ischemic time. The length of stay was about the same between the 2 groups. You can say, well, the Sherpa packs were a little bit longer. Trying to control for some of the other patient factors, it does sort of even that out a little bit, but I won't get into the gory details here. PGD rates were the same, and when you look at EF, both at 6 months and 1 year, there wasn't any difference, and the overall ejection fraction was normal, about 60%. When you look at overall survival, the red is the Sherpa pack, the blue is preservation and ICE, and there wasn't a statistical significant difference, and survival was actually pretty good for all of our patients. This is a little bit complex. I tried to sort of say, well, if you look at ischemic time and look at length of stay, maybe we could capture a sense of sort of the patients that struggled with primary graft dysfunction but didn't quite require mechanical circulatory support. So the ICE is with no PGD is a blue plus. If you have PGD, it's a red plus, and the same thing with Sherpa except for circles. And to make it a little bit easier to see, I sort of separated them out. So you can see in our ICE group, we had PGD that was sort of all over the place in terms of ischemic time. There wasn't necessarily a relationship to longer ischemic time. We saw the same thing with the Sherpa pack, maybe not quite so much PGD in some of the really short ischemic times, but again, not a huge association. What about, I'm sorry, this doesn't actually project very well, but we looked at sort of donor age and ischemic time because we wondered, well, maybe we're only going really far for young donors, right? And so when we look both in our cold ice experience and our Sherpa experience, if donor age is on the bottom and ischemic is on the y-axis, you can see there's really not a strong relationship between donor age and how far we're going. So we're still going far, and oftentimes for donors that are on the older side, as Andreas alluded to, is what they're doing in Europe. So, and again, procurement is changing. I think we're going longer and longer distances in the U.S., but the flip side to that is we're getting our patients transplanted more quickly. You know, we're a large, aggressive program, and we're looking for ways to go further to get our patients transplanted. And our initial experience kind of backed up by sort of a longer experience, so again, not as long as the overall data that you see in the larger database for Paragonics. We've been pretty comfortable going longer distances, having good outcomes for our patients, both in terms of need for mechanical circulatory support or just sort of longer hospital stays. We really haven't seen that in our patients who we've gone very long distances. So again, I think maybe in 50 more years, I don't know if I'm going to have a picture up there to show you that I'm still alive in 50 years, but hopefully we'll be doing something beyond just putting hearts in ice. Thank you so much.